Hello and welcome. Today's interview is with Michael Ash, a co-founder of Prescribing Lifestyle Medicine. I recently attended this course online. It's designed for GPs and other health professionals. When I attended, it had over 550 clinicians attending. As Michael explains, the principles of prescribing lifestyle medicine are that with some simple lifestyle habits, you can turn someone's life around. The course came about as a result of the really successful BBC TV programme Doctor in the House, in which celebrity GP Dr Rangan Chatterjee was given 30 days to reverse chronic health conditions with simple lifestyle changes. To the surprise of many people, it worked. In this interview, Michael and I cover some really interesting topics. It's an extra special conversation, and I hope it will give you some encouragement for being more decisive about your health in 2021. Enjoy. I really just wanted to start with an overview of your sort of professional history and how your training in osteopathy and naturopathy has influenced your career, and maybe how and explain, from that start point where you got to prescribing lifestyle medicine.
I trained as an osteopath back in the 1980s and naturopath. I did a double diploma at the time over a 5-year extended pathway course, whilst I also started an undergraduate practice. And I had a great interest in professional athletes at the time. So by the time I qualified, I had over 3,000 patients had gone through my practice, and I was looking after some of the elite athletes, not only of the UK, but also from other countries. I then decided that I needed to know more about nutrition for performance. And I started going to the States in the very early days for both orthopedic sports medicine training and early stage specific performance in nutrition training. There was a guy called Robert Haas wrote a book called Eat to Win. And I utilized a lot of the material from his work. We didn't have internet in those days. You physically had to just get on a plane and go and listen. And so I began to develop a subdivision of my musculoskeletal practice into performance nutrition. And then I progressed from that. I did another 3 years training in nutrition. And then I came across a guy called Jeff Bland, probably 27 years ago. And shortly after I met him for the first time, and I was working a lot with very specific energy generation nutrition. So I was working with people where we're looking for a 1 or 2% variation in performance. Most of these guys were either world champions or in the top area of their sport, and we're looking for very small margins of gain. And we were doing quite well. And I picked up a lot of people who were very ill with fatigue from sport. So the sort of early stage post-fatigue or what became chronic fatigue or ME type symptomology with previously very high performing individuals who had burnt out. He presented a presentation on mitochondrial dysfunction back in, I think, 1993 or 1994. And I thought, wow, this might well be an area that I don't really know very much about, but it seemed to fit some of the problems I was seeing. So I went to a conference in Canada for the Functional Medicine, Institute for Functional Medicine's first or second conference, I think. And I found that very interesting. There were a lot of very innovative speakers there. And I sort of moved my whole clinical work into adopting some of the early stage functional medicine principles, some of which we have diluted down to our prescribing lifestyle medicine. So it's a systems-based approach, looking at 7 intersecting systems simultaneously, working way back upstream to look for a causal or a mechanistic intervention that may be able to unwind damage or dysfunction, which ends up creating someone feeling unwell. My practice grew. I became, pretty successful. I was seeing 100 patients a week. I added more clinicians. So I had GPs, orthopedic surgeons, psychiatrists, rheumatologists, massage therapists. It sort of grew arms and legs. These things tend to do. I began speaking or teaching a fair bit at that time. I was going back and forth to the States. I also started a supplement distribution business at the same time to meet the needs of the patients that I was seeing that we couldn't satisfy with the availability of UK or European food supplements. After 25 years, I decided that I was just about at the end of my tether.
From what then? From what point of view?
Really, well, I moved from elite athletes into people with neurodevelopmental problems. So
Okay.
I wrote some papers for gastrointestinal dysfunction affecting physical performance and also psychological performance. And the consequence of that was I got asked to look at whether there was any connection between gastrointestinal immune dysfunction, immunity. I've been doing postgraduate immunology training now for 20 years.
Yeah.
And so I wrote a paper with a couple of gastroenterologists. We published it. It got a fair bit of exposure. And I got phone calls from people who had family members with autism. And so I knew nothing about autism, but I dived into the subject, and I was treating at one point over 300 families simultaneously, which probably put me in the area of one of the most swamped individuals at the time for that. And I think that I moved from elite athletes into family medicine, into this very subspecialty of neurodevelopmental medicine, whilst at the same time cultivating this super general practice approach to people with a variety of intersecting dysfunctions. So a reason I mentioned those three things is I started with high-performing individuals, finished up with high-performing individuals, but with a significant alteration in their translation of external stimuli. They got either hyperstimulated or hypostimulated, and the gastrointestinal tract for me was an obvious place to target safe and reproducible interventions.
So are you saying someone with autism there, they are suffering, I've heard different people explain this in different ways, but they are hyperstimulated. That's what gives rise to some of their symptoms.
Some of them are. I mean, there are different levels of functionality. So within the spectrum, there's a wide range of mechanistic dysfunctions. So if you become linear and look for a fairly standardized dysfunctionality in a group of people with complex disruptions to their normal biochemistry or their metabolic function, you'll sometimes pick up, and you might pick up half a dozen of those and you do quite well, but you meet your seventh person that doesn't have that same pattern. So functional medicine, if you like, provided a network of thought processes that you could then translate into that individual's needs. And it certainly teaches you not just humility, but also a great deal of requirement for postgraduate reading, because I know you invest a lot of your educational training into becoming expert in different areas. And I think when you get highly energized, it creates a hunger for resolution, which comes from a higher level of understanding, or at least as best you can.
So you say hunger for resolution. You're talking personally there, that you want to resolve, when you see a problem, you want to help resolve it with your knowledge and continue that knowledge. Is that what you're saying?
Yeah, absolutely. Yes, I think improving highly individualistic performance in individuals was a tremendous enthusiastic point for resolution for me initially. Then that became easier through knowledge gathering, and it becomes less of a challenge, more of an application issue. So it becomes more of an administration process rather than a discovery process. You have a certain number of practicalities which you can utilize to uncover that person's specific needs, and then there's an application depending on each individual's willingness to comply. You can generate an improvement in their immunity, their recovery, their restoration from injury, and their consistency of avoiding irritating or minor illnesses that knock them out of their performance routine. People with neurodevelopmental problems require that same process of trying to work out which of these pathways may be interfered with, but the outcomes are very different. You're not looking to add 1% to a miler. You're looking to add conversational speech or sleep patterns or removal of pain or reduction of medication. So it's just a slightly different process. And I found it very interesting, but I also found it very exhausting. So at the end of that, I did 25 years of full-time practice, building that up. Then I had an offer to sell my practice, which I did, and continued to work there for a while whilst I developed my educational training programs and our distribution business. And I was already speaking internationally, maybe 3 or 4 times a year, but I expanded that around the world. So I would typically teach maybe 3,000 to 3,500 clinicians a year. And again, although there was some early stage online training, it was physically getting on a plane, going to Australia or New Zealand or America or Brazil, wherever it was, and then teaching. What I was really based around changing immune mechanisms to produce tolerance to different stimuli.
Right. Yeah.
So your hypersensitivity issue, or your hypersensitivity element, is frequently based on the fact that a normal response to a trigger has become disturbed, and the immune system is inevitably deeply embedded within that process. And then learning how to use non-pharmaceutical means to reprogram the immune system to dampen the response was something I spent many years fiddling around with and working with. So roll that forward.
Yeah.
I was now an educator for the Institute of Functional Medicine. So I was teaching mostly in the UK, but periodically in the US. I brought over the Institute of Functional Medicine's training programs to the UK. And as a result, lots of interested practitioners would contact me for advice or guidance about either taking the course or maybe even some clinical nuggets that they felt might work.
Yeah.
And one of those clinicians was Dr. Rangan Chatterjee, one of the co-founders of the Prescribing Lifestyle Medicine. And Rangan contacted me as a referral from one of my colleagues in the States about an immune disruption in his son. And so we began working together, and then he decided to train in functional medicine. And so I would act as a sounding board and a mentor at that stage to the usual clinical conundrums that anybody does when they shift the practice modality. So if you go from a 6-minute general practice appointment to a half-hour, more involved prescribing lifestyle medicine type appointment, that mental shift takes quite a bit of pivoting at times. And your armory of options seems quite unfamiliar to you when you first begin, and you're uncertain about them. There's a degree of apprehension, and you're trying often to translate one to your existing skill set, and those don't necessarily overlap very easily.
Right. Yeah.
Even if the outcome is mutually consistent, the process or the options that you have seem a little bit nebulous or perhaps frightening to begin with.
For people who are listening to this who aren't aware, the idea that the Prescribing Lifestyle Medicine course is based on the idea that our lifestyle choices can influence a person's, physiological systems or biology, and ultimately their health. In principle, that sounds really simple, and there's a huge amount of research that backs it up. And you were an early pioneer, or you were exposed to the idea of metabolic dysfunction more than 2 decades ago, by the sounds of it.
Over 3 decades ago.
In the Prescribing Lifestyle Medicine course, you referenced so many examples and so much evidence of that. Why do you think then that it's taking so long for this to become kind of more mainstream, and why some GP practices may still struggle with this concept?
Yeah, that's a question that gets asked in every country, and there's a principle here, which is that in medicine, things don't change till the person who thought about it dies. So you've always got a fairly long curve of transition. Where I think, I don't know whether you know the program Doctor in the House. Did you ever see that?
It's actually my clients who said they'd seen episodes and said, you'd love this. And that's what, switched me onto it. And ultimately led to me finding your course. So okay. Absolutely.
So, circumstance opportunities come along. So I've written book chapters, published in peer-reviewed journals, written hundreds of articles, thousands of blogs. And you keep thinking this information must be permeating somebody somewhere. And then Rangan had an opportunity to do a TV program. And so he asked me if I would help, because we both felt this was an opportunity to get lifestyle medicine in front of the general public. But it's a big jump for somebody who's relatively, in those days, early in the process. So we did a pilot program with the BBC, and they gave us a family of the people who were had at least 4 or 5 chronic health conditions, and gave us 30 days to reverse them. So we did that, which was a bit of a surprise to me, as well as to BBC. But the power of having a TV crew in your house, it really aids compliance. So I think it's important to understand that compliance delivers outcome, and outcome is definitely enhanced if you've got a TV crew filming. But the BBC really liked that, and they offered a series to Rangan, which gave us the first, I think it was 6 programs. And so we ran 6 families with complex health problems who've had many years of unsuccessful interventions from traditional medical care. And in every case, we reversed those conditions within 30 to 35 days. We were the first people to show a reversal of type 2 diabetes on TV.
Wow.
And it was an experience for both of us. Rangan's a talent. He's the guy that everybody sees, and he's absolutely, fantastic at communicating. He's a brilliant clinician. I'm the person that has to pull together all the research, the explanations, and get it past the BBC legal team to explain why we're going to do what we're going to do, and then Rangan applies it. So we thought that was Rangan offered a second series, so we did a second one. They tried to make it harder. They tried to make us treat 3 people per family in 30 days, which we did again.
Wow.
Obviously, the program's only for an hour. We do between 4 and 6 weeks work. It's quite a challenge. We only get told what the problem is of a piece of paper a week before Rangan meets the families. We only get the lab test 24 hours before it starts. So it's quite a challenge. You have to put together a program really overnight, and then you start the next day with them. But I think what your client or your patient saw, and so did 6 million other people, that was the average viewing figure per program, was that very difficult to resolve heart sink problems without using drugs can be resolved. And that energized the Royal College of GPs, and they contacted Rangan to say, can you come and tell us what you're doing? Now, obviously, a 60-minute program with 3 family members and 20 minutes per person, as opposed to 6 weeks of oversight, analysis, intervention, you lose maybe 70% of the story. But it's good TV. So, a lot of happy, healthy people at the end of it. And I think that question you asked me, why aren't more people in the NHS or elsewhere making this change? I don't think they've ever seen anybody from their own world perform these sort of interventions in such a way that people they recognize as turning up at their practice on a weekly basis with the usual heart sink feeling, what do I do for this person? I mean, I just don't know what else to offer them. Suddenly could see that actually with relatively simple strategies, you can turn someone's life around. And so Ayan Panja, who was the other GP that the 3 of us, and a guy called Jeremy Hawking, who does all the background admin and the organization of the business model, who's a co-director with me here, felt that this story, in order for it to enter the NHS or for public healthcare, has to be shrunk further. It has to be hung onto a very simple structure that is safe. So first, do no harm, effective, and validated. So those are our 3 parameters. What's the least risky, most effective, well-supported intervention? You know that if you're working in an environment in which you have a historical patriarchy of belief, someone comes in and says, you know what, I think you're doing this all wrong. I've got this great idea. I want people to do time-restricted feeding. I want them to only eat meals on certain days a week. I want them to avoid wheat. I want them to avoid gluten. You're going to get shot down because you're not arriving with a proposal that feels comfortable with the existing knowledge base. And so I'm hoping you found this, but with PLM, what we try and do is weave together existing knowledge that GPs and primary healthcare professionals and also other healthcare professionals already hold, some of which are slightly more in our world than others.
Yeah.
And then intersect the two systems through a safe early stage. I mean, obviously we're already teaching a very simple process at this point, but through a safe process that gives people the empowerment to experience or experiment, so that we're giving them permission to use their existing knowledge combined with some well-supported recommendations to identify the enthusiastic participant and create that shared responsibility to help move them forward. And with that comes a release of that historical reason why you got into medicine in the first place, which is I can help somebody take responsibility to make their life better. And that's a thrill that never goes away. You know, if you yourself, if you recommend something to somebody who's stuck and they come out and they say, gosh, you know, I haven't felt this well for years, then your day's a lot better than if it's I feel no better.
For me, it's about empowering people to improve their own lives. My career started it was the Innate Immunity Group in the Centre for Inflammation Research, funded by the Medical Research Council. And we were studying what you talked about this, you know, this immune dysfunction when patterns, the pattern recognition system gets confused at the cell, you know, at the cell level of the cell surface. At that time, you know, I didn't know I'd end up here, but I was the whole story that I was under was that we were doing this so that we could create diagnostic tools or pharmaceutical drugs. And at the time, it didn't really click to me the potential for applying all of this. Well, in a sense, it did, because I became interested in lectins back then. But generally, I didn't see the power of just understanding these. The microbiome and autoimmunity and so on. And what I really liked in the Prescribing Lifestyle Medicine course is that you, as well as keeping it incredibly simple for the practitioner and the patient, you also gave some mechanisms for those who want to dive into the mechanism. With food, for example, you know, you explained that by changing the type of food that you eat, then that will influence different populations of microbes inhabiting your gut. And then the consequence of that is that those microbes will manufacture different immune modulating chemicals, which will then affect the person. It's like a medicine cabinet in their gut, or the opposite of that, you know, a poison cabinet, I suppose. So, you know, it's when you break it down, it sounds incredibly simple, but it's not always, you know, there's still this belief that no, I can't create these changes myself. I have to rely on a manufactured drug. One question: do you think it's possible to extend that principle further? So you've mentioned in Prescribing Lifestyle Medicine the importance of the microbiome, for example. Can we extend that to soil ecology and look at the quality of the microbes in the soil, which then affect the type of food? This phrase, food is information.
Yes, I mean, you're taking the natural step backwards, and I know we just highlight one paper and a couple of comments about how global warming is increasing carbon content in plants and therefore driving up sugar content. Makes plants grow more, but they contain more sugars, and as a consequence you see a compression of minerals. And then poor soil management means that soil is less able to release minerals through enzymatic process. And because of the exogenous application of various types of plant growth or plant protected mediums, insecticides, herbicides, and fertilizers, we've seen a similar effect on soil composition to that in the gut with antibiotic use. So the phytobiome, which is the term used to describe the organism complements each other within the soil, can be thought of fairly in parallel with the microbiome.
Right.
So we have a population of organisms that we're gifted at birth. We maybe add a little bit to as we go through our generational growth, and we lose some, of course. And we can look at it the same way. If we look at a piece of land that's been super saturated with risky or risk profiling processes, which typically leads to a diminution of organ density and variation, which loses the innate capacity of the soil to facilitate innate production of defense molecules in plants,
Mm-hmm.
then we see exactly the same thing happening in plants. You become more and more reliant on third party to artificially support them in the face of challenge. And we see the same thing with humans. We rely more and more, whether it be food supplements or drugs, we rely more on exogenous elements to either suppress in the role of medication or supplement in the role of food supplements, the very component that's being lost through agricultural practices. And some countries are worse at this than others. North America, one would say that they perhaps demonstrated more efficiently than any other population in the world the metabolic dysfunction associated with poor food choice over a period of a few generations. And we cover, as you know, the triad of inflammation, oxidation, and immune dysfunction as the three fundamental drivers of ill health and defense, of course. But if the defense isn't managed correctly, it becomes a provocateur for ill health, of which there are many ways of triggering any one of those three, but they become self-sufficient. One drives the other. And you touched upon this, is that you can choose to consume foods that favor an anti-inflammatory, immune regulatory, and a antioxidant approach.
Yeah.
Or you can choose foods that do the opposite. And the notion that was essentially a 1960s hippie fantasy has been subsequently eroded over time as more and more researchers discover that correctly grown food carry a power through multiple points of intervention, which are quite light on touch, but are wide-reaching in terms of their opportunity. So going back to your research work, you'd be looking for maybe an enzyme inhibitor or a receptor blocker, which would be quite powerful, with the subsequent risk that there are unintended consequences because you're interfering with other pathways.
Yeah.
What we try and do in the prescribing lifestyle medicine is show that choosing repeated applications of low-grade enzymatic inhibitors or enhancers or receptor cell binders is soft background music that you slowly evolve a evolutionary response to, as we would have done for thousands of years, hundreds of thousands of years, rather than the big rock concert effect of a drug. It's very exciting to give someone a medication that stops a progressive acute illness in its tracks.
Sure.
Antibiotics have demonstrated, as many others have, fantastic life-saving events, but most people kill themselves slowly over time. And we want to try and intervene in that process and regenerate health and vitality. And yes, on a single day, as you'd imagine, we can only touch on these parts. But hopefully what you saw was that depending on how enthusiastic you are, you can waste the next 30 years of your life following one single receptor site for the binding compound from a food that's degraded by hydrochloric acid, if you wish.
Yeah, my hope is that all this knowledge over time will be used in the best way, and we'll gather this picture by having the approach where we're dismantling everything and breaking it apart and trying to be a reductionist. We then build it back up and look at things and whole systems again, as you do, and not just systems inside the body, but system, societal, cultural, and environmental systems. Which that was another nice thing about the Prescribing Lifestyle Medicine course, and you cited some research about the power of community, the connection between the GP and the patient, and how important that is for healing. So as more research comes out about that, I think health will be viewed in a completely different way.
the meaning response, which is essentially the ability to transfer a level of control to the person's receiving information, but they're receiving it in a way that it makes sense to them.
Mm-hmm.
The gift of providing someone the opportunity to take responsibility whilst being secure in the knowledge that the person who's giving that gift will support you carries with it a strength of change in that person's immune system, their psychological well-being, their whole metabolic system that's very difficult to quantify. We can't necessarily say, oh yes, I was marvelous today, I gave this person a 3-score meaning response and they'll be better by next week. It's a bit nebulous, but when you receive it, when you actually if you're in need of help and you receive that from somebody, the effect doesn't last for a few minutes, it lasts for weeks. And GPs or primary healthcare professionals carry a like a force field of expertise that sometimes gets denuded by a failure to engage with the requirements, both socially, psychologically, and metabolically with the individual. And lifestyle medicine gives you a platform to provide all those 3 things or more without you having to look for your MIMS or your BNF to find a choice of medications attached to a particular diagnostic set of symptoms. It's more a case of saying, well, why don't we share in this process? I think if you were to change your sleep habits, if you were to perhaps exclude something from your life, and as you know, I talk about the 2 things. If you panic in these situations, there's just 2 things to really remember, and this is not my work. So a gentleman called Sid Baker, who's a doctor in the States, taught me this 30 years ago. There's 2 things to remember. Is there something that is causing this person a reason or a problem in their health that you could remove, that you could suggest to them that they remove it? Is it somebody, something that needs to be taken away from their life? And then on the other side, the counter argument, is there something that we need to add into this person's life that satisfies a need, whether that's nutritional or psychological or social? And if you approach people, it sounds a bit binary, but there's lots of variations in there. It empowers that discussion and takes fear away from what do I do for this person who comes perhaps sometimes with 6 intersecting autoimmune conditions. You've hardly ever heard of 2 or 3 of them. And then you only have a sketchy memory of it, and they're there. And if you go back to think, well, tell me what your typical day's like. Tell me sort of meals that you have. Where do you live? What's your job? Is there something in there that I might be able to suggest you change for the better? I can help you with it. Maybe we add something in that. Obviously, we discuss everything from mindfulness to exercise. The point is you have a very big armamentarium. It's just making them fit together for that person.
As you said, it can sound a bit binary, but that move from being in a state of threat, perceived threat, to a state of closer to a state of safety, that's going to have an immediate soothing effect on the body and be changing the whole soup of chemical reactions that's going on. I don't know if you're familiar with the work of Stephen Porges on his polyvagal theory. And he's working at the moment with some medics in America looking at cytokines and how that links to various different conditions, autoimmune conditions or other chronic conditions. What's your sort of vision for healthcare over the next decade then? Where can we, so the Prescribing Lifestyle Medicine course has been a success. Hopefully that will continue, and I've seen there's a new partnership for its delivery next year. Is that where it ends? Will that just roll out now, and then the nation or the world will start to know how to look after their health better? Or is there something else you can see as needed?
There's a continuum of need. So it's circumstantial. If you fix people at the lower end of the need, the next level then effectively attract your attention. So looking at any form of education, particularly medical education, where there is a slow progressive translation of ever-evolving information. So you just mentioned a colleague of yours. Well, the Psychoneuroimmunology Research Society have been exploring the role of cytokines in both psychiatric and physical function for over 30 years. But most people have never heard of cytokines and have no idea what they do. There's over 300 of them, and tracking what each one does in its isolation is, again, that reductionist view that we were just bouncing around. So if we were to say we don't want to have a reductionist approach, but at the same time we have to have a simplified approach, which is where PLN starts. The next phase we're doing is to make this available to people at their own time, which we, as you may or may not know, we did our very first video-based training. We had over 550 clinicians attending that. So in a room, we can only get to 200.
Yeah.
So going over 500 was a big jump for us. In fact, of course, you were part of that. So it was good to get over that number.
Yeah.
The organization we're working with has access to all GP surgeries in the UK.
Incredible.
And there are two things that have attracted us to this. One is data collection, because we can give you great anecdotes and one-on-one cases, because that's typically the way that we operate. We can collect both preclinical and clinical data in larger studies.
Yeah. But
they become a little difficult to quantify when people are applying slightly different strategies in their clinic every day. So the idea is to, and you would have seen there's a medical record template that's been designed. The idea is to create the opportunity for primary care physicians to identify by diagnostic means, which are recognized as being contemporaneously acceptable, assign that individual to a lifestyle medicine intervention, and then track them. And then the organization we work with will anonymize that data and draw it back into a series of reports that allow us to see whether what we believe to be a very successful one-on-one intervention can actually be materially impactful across maybe, let's say, 2,000 GP practices across the UK. If you make primary care physicians, if you provide primary care physicians with this opportunity to develop, evolve, and report back on a successful process of changing people, that is a very powerful noise for the decision makers, because one, we know we reduce prescription costs typically by a third. We reduce attendances at GP surgery typically by about 20% on the small group that have been supplying us as feedback. We take stress away from primary care physicians because they've got a little bit more time, and they also have a set of safe interventional tools. And that ultimately provides a dialogue opportunity to have a slightly extended period, because every GP is compressed by time. And they all think they could do more if they had 10 minutes or 15 minutes or 20 minutes. So, but to give them that time, you've got to try and make the patient load decline, or move them across to people within the surgery, secondary care practitioners, nurses or nutritionists or physical therapists that can pick up some of the workload and translate the need into a managed care process. So where do we want to go? I mean, we have moments of grandeur, of course, where you want to think that PLN would be a standard of care. But as I say, 35 years in, I'm aware these things can take quite a while to shift. We have been approached by a number of universities, not just in the UK, but internationally, that want this to go into undergraduate medical training as a part of the curriculum. So
excellent. We're
negotiating with a couple of those to see how to pick up our recorded versions of this and bring it in. And I suspect that there's an attitude in young students, well, I know there is, we get a lot of feedback, a lot of young medical students are hungry for this information. They want comfort of evidence, but most of their tutors are still teaching interventional techniques that were taught to them. So there's that slight wedge. There's a bit of a wedge you've got to sort of drive in there, and that meets resistance, and one can't imagine this is without ups and downs. But I think we found, I hope you felt the same. I think we found a language for the first one that worked, and now we've had hundreds of requests. We've trained over 1,500 GPs now, hundreds of requests for, can you do an advanced presentation on? And normally they always want it on a subject that they have a particular interest in.
Right.
But we've done presentations at Birmingham University for the rheumatology department. I've just done I've just got to re-record it because unfortunately the slides didn't come through. I've just done an update version on the use of probiotics, which is always a subject that confuses most primary care physicians. And so we're going to slice our way through, build up a larger and larger network of self-help. So I know you've written some books, you've done some presentation work, you already have a good grasp on how to translate much of this into clinical care. So it's getting people like yourself that's involved to help others who are hungry for information and forming that collegiate supportive network, as opposed to that competitive inhibited development that tends to come through people climbing the promotion ladder. What we try and do within the community is to say that actually, no one knows all the answers here, and someone's probably got some great ideas that we've never heard of, and others have got some ideas that may just need a bit of shaping, and that's what we try and do.
Great. And I think with all that data collection, by the sounds of it, then there's a huge scope for gathering more evidence of different styles of approach as well for delivering the lifestyle medicine. And when you said partnering with universities, what I thought you were going to say was for not for delivering the course to undergraduates, but for gathering the evidence and finding out what works best. And maybe for what conditions does it work better for, let's say, type 2 diabetes than it does for sleep disorders or something like that. So really exciting. Do you think, what's your thoughts about the explosion of devices like the Fitbit and other wearable devices and home test kits? I sometimes use Thriver or Nordic Laboratories. All these types of things are becoming more accessible to the layperson. Do you think there's a kind of way that the NHS could work? So at the moment, you have to go to the NHS for a test. And if you want to do something privately, then that's on, they don't really advocate that. Can you see a way where those two worlds can join?
Well, I do. And I've been involved in a number of grant applications with colleagues that have been looking to start to utilize less traditional analytical tools than would be familiar to the standard hospital operation. Now, that can include electronic measuring devices, but it may also include some different types of blood sampling. And what I'd say is that, for example, I'm not very far from Exeter University here. I mean, they're doing a lab on a stick. Been doing that now for a few years, where you can measure 6 parameters on a small blood spot, plug it into a capturing plate, put that into your mobile phone, and you download an app, and within 30 seconds you can analyze that blood and from blood sugar levels, cholesterol. There's various parameters that you can utilize. Now, in principle, there's only a certain number of things you can do with a finger prick of blood, but the point is that offering that ability within surgery for a start would make a great help. You can take a sample 30 seconds later. You don't have to do a big blood draw, don't have to send it away. I think that's very useful. So there are definitely projects where they're aiming to fill that gap within the NHS. So they're looking to produce tests that are quite adventurous, but satisfy NHS requirements. Then we have the other area, which is where there's more, let's say, augmented reality, innovative activities where people are collecting data which far exceeds the skill base of the primary care physician, whether this be genetics or whether it be 24-hour monitoring, heart rate variability. Very useful, and in many cases entirely valid data. But if the person who's collecting that data doesn't have a broad enough parameter to interpret it, what I've seen over many years is there's a degree of anxiety that can get driven by a set of results that in isolation look quite worrying, but in a broader understanding of what's going on in the body, actually doesn't cause too much stress. Uncertainty in application generates fear and anxiety. And medicine, the art side of that, is taking the uncertainty and applying it in a way that's safe with a reasonable expectation of outcome. You don't provide somebody with a pathway to do that. And you can't go from, I don't know very much, to I can pick up this set of samples and in 30 seconds can make a determination around it in a week. That takes years. So I think that AI, the medicine, will start to fill some of those gaps so that the journey of both the patient and the clinician is protected, because they're utilizing years and years of experience from other people that have contributed to that interpretation power. And then the last bit is, I know this person better than anybody else because I've been looking after them for 10 years. I'm going to shift my emphasis towards this side of the suggestions than that one. And I think if we could take data, run that through a multitude of intellectual input that's been written into a program, so that within a few seconds you've got a series of reasonable, safe, or perhaps slightly more risky choices, and then you've got that human interaction. You can't just ask a computer to make you better.
No.
You need that. We've all done Dr. Google. It doesn't work terribly well. You need to have, like we're having now, that dynamic, because that process we talked about, empowering somebody for weeks, comes from that.
The point you made at the beginning about compliance when people were involved in a TV program, the likelihood of them creating a new habit that would last and become integrated into their life, and or maybe giving up some habits that that they don't want to return again. I agree that would be more likely to happen if the suggestion was delivered by a human rather than just a machine or a readout. Reminds me, I know someone who, and maybe this isn't the best health example, but they manage a lot of franchises for McDonald's here in Peterborough. And every year they go to the like a conference at the McDonald's headquarters. And a few years ago they went, and part of the conference was to go on a tour around their R&D lab, I suppose it is. Now there's a section they said that no one's allowed in because it's top secret. But what they did learn is that the future of McDonald's drive-throughs is going to be AI. So you read your order out when you drive in, and then inside it's like a food factory that it's just there's no people actually cooking it. But they said what they still will keep is they'll keep the person handing you your bag afterwards, because they know that's I guess it makes it taste better if it's
there's your career opportunity. Yes, the McDonald's bag transferee. Medicine and law and accountancy are the three professions that are most vulnerable to some form of artificial intelligence. And frankly, some of them need it, because there are errors made in law and accountancy and medicine every day that would be stopped by having an appropriate artificial intelligence machine that could do a run through. Because we have failures, there's always failures in medicine, even in lifestyle medicine, there are failures because on that particular day, a decision was made because that person had a bad morning, or they're exhausted, or they're tired, or in some cases they're under the influence of medicine or drugs or alcohol. And having a friend, if you like, I mean, I'm sure you've had this experience, is that people always say, if I knew what you knew, can you just download your brain so that when the next person comes in and says, I've got, Sjogren's disease with rheumatoid arthritis, I don't sleep very well, and I've got vascular complications, what do I do? Rather than thinking you've got three different complaints that you have to try and simultaneously treat, you think of that oxidation, inflammation, and redux issues. Then what happens is you can think coherently around that process rather than having to think about each individual disease. And so having a process that allows you to take away that worry of not being able to remember everything and project to you the electronic version of a BNF from a lifestyle process, I think will be terrific. And but it won't be here next year. It'll be, at least another decade or so before that makes it out.
Nice to hear such optimism about the future at the moment. So is there anything you want to say before you finish? Any kind of message for 2021?
Well, I hope that I'll be able to get to a hairdresser in 2021, because I can see I haven't been able to go for weeks, and I can see I desperately need to go. So 2021, I think, it certainly needs to be clear. I'd say that 2020 has tested people's confidence in science, medicine, and it's certainly tested lots of medics in work. It's thrown up an opportunity to hear quite diverse views, whether that be political or views around the risk of viral mutation, etc. I suspect more people have been aware of epidemiology than they ever want to be in their life. So I would like to think that there's a chance that people will carry forward some of that experiential processes to change their lives accordingly, not just for themselves, but for their families, their community, and ultimately, although it's a very big notion, but for the food supply and for the planet itself. And out of that, I'm absolutely sure we're going to get groups of individuals. I know we already have. There are groups of individuals who are driving forward now, ideas that may have been 5 years further down the road that will come to fruition next year, particularly in agriculture and food production. I think there'll be some powerful shifts. And I think that's something we should be optimistic about. And ultimately, we're all a little bit more knowledgeable about the resilience required in humans to survive pandemics. Resilience is not found in a bottle of medicine. Resilience is found in what you do every day.
Absolutely. Great message. Thank you very much.
All right. Well, look, thanks very much for inviting me. I hope some of that was helpful, and we'll hopefully speak again in the new year.
Yes, thank you.
All right. Bye-bye.